I am looking at very interesting statistics here, and this is specifically on matters that concern, our peers across the globe. And allow me to read through so that we are able to come into a conversation. So, as of late 2024, 19 countries and territories have been certified to eliminate mother-to-child HIV and syphilis transmission. This is according to Pan American Healthcare Organization. In Maldives, if you know this very interesting destination for tourists like yourselves, was the global first to achieve validation for triple elimination of HIV, syphilis, and hepatitis B in 2025. And some of these statistics that we'll be going through and looking at will help us try to position ourselves and understand what needs to be done in order to address the issue of maternal health care. Again, let me try and see if I'm able to get Dr. Lutta. Dr. Lutta, can you hear me? Good evening.
I can hear you loud and clear.
Tunakupata sasa vizuri vilivyo inavyowezekana. Issue ni moja bwana kakangu. Ulikataa ile mtambo utabadilisha kabisa. Nataka kutumia mtambo ambao umeenda shule.
I'm trying to use my phone, Mr. A.
Yes.
But I find that the laptop is suitable. Because I don't have now like you'll carry a phone. You know, I'm not so much of the gadget.
Unfortunately, your audio is blipping, so we are unable to get you on the call. Maybe I will try an alternative B.
Let me use now the phone.
Yes, please.
We'll just have now to use the phone.
Kindly.
So.
As we do that, and again, maybe you'll exit on this session so that you're able to join with the normal session. Otherwise, you'll have double stream, which can give us problems. And ladies and gentlemen, these are the challenges that come with live broadcast. And the fact that you guys are very patient and willing to wait is what keeps me going. So if you would love to find out more about Court FM, I want you to now dial up www.kotfm.co.ke. Namwona daktari kidogo amejiandaa pale. Nataka sasa nimwambie tu adjust kidogo, kuna kitu inafunika kamera yake, alafu wakitoa ndio tutamleta sasa vizuri tuweze kuongea na yeye. And you'll bear with us because it was very reasonable for us to have this talk from the aspect of rural Kenya. Some of the struggles we have with rural Kenya is not just the issue of healthcare. It's allowing this accessibility to healthcare and technology that helps in addressing serious issues, especially when the issue of mother and child come into play. Remember, when you look at the African tradition, when a child was announced to be coming to join the new family, people will celebrate. In fact, the mother will be treated as a queen. Everything and every service will be made available to her. And that's why I want, once Dr. Lutta correctly positions his camera to the eye level, I will have him to come in. Sasa ndio asiwaangalie kama ako benguni. Najua mnapenda kuona watu sana. Na ni kijana handsome. Msifikirie ni mchezo. Haya basi daktari, mimi kabla tuendelee na mambo mengi, ningependa sasa uje hapa uamkue wetu wenzetu ambao wamefika hapa, na asante sana kwa kujitahidi na kufika hapa ili tuweze kuzungumza sana kuhusiana na mambo ya tiba na haswa katika akina mama. Haya basi, Dr. Lutta, good evening. If you can hear me now, you are live on air.
Good evening, Mr. Eli. Am I audible on your side?
You are very audible and very, very happy to have you joining us on the call. How are you doing, sir?
Very fine. I hope now the visibility is a bit fair.
It's fair,
Maybe
and that's
not perfect, but a bit fair.
And that's why we are looking at this topic from rural Kenya. What it means to people in urban centers, it might be a different ball game altogether. But I want to allow you the chance to not just say hi to us, but also introduce yourself to our viewers. Kindly, sir, proceed.
Thank you, Mr. Eli. It's a great opportunity for having invited me to this platform. I'm Dr. Ismael Lutta. I am a senior medical officer working in Kakamega County, but I'm also a member of a Kenya Medical Association and more so in the Committee of Public Health. Mr. Eli, I'm also a champion for sickle cell disease and a champion for maternal care. That's what I can say for now.
Awesome, awesome. And we are very honored to have you here. I know now that you've made us aware of who you are and what you do, it's going to make our conversation much easier. Probably let's just start from where we should be starting. Maternal health care. When we talk about maternal health care, there is a medical definition of what it is all about. Probably that's where I want you to start, sir. What is maternal health care and what does it involve?
When we talk about maternal health care, it's the care of women during pregnancy, during birth, and 6 weeks after birth. That entails maternal health care. So you want to take care of their journey through pregnancy while they are giving birth and the 42 days after giving birth to ensure the process is seamless and we achieve a healthy mother and a healthy baby.
So the process, it's pre and post natal, right?
Correct.
Awesome. Now that we have that and we understand what it is all about, I would like for you to break it down to me, but now from the perspective, not just there's the general aspect of the status of maternal health care in the country, but I will really want you to focus on rural Kenya. However, feel free to start from the national outlook. How does it look to you as an individual that is in the field every single day?
First, Mr. Eli, let me thank you because what we are engaging now is advocacy. And I want to thank you because people rarely talk about maternal health care and maternal mortality. So to get you as a journalist being interested, even though you don't have that medical background, it makes us to feel very happy. It's giving us the vibes that other people, other stakeholders are interested in it. So I really want to thank you for delving into this topic. So for the status of our maternal health care, we will use one indicator today to show us what is the status of our maternal health care in Kenya. So that will be maternal mortality. And basically in maternal mortality, the way we define it is any death of a woman during pregnancy or when they are giving birth or within 6 weeks after giving birth. In Kenya, the current maternal mortality is 355 deaths per 100,000 women giving birth. Let's compare it. This data, let's break it down. What does 355 deaths per 100,000 mean? It means every year we are losing 6,000 women per year. Let's compare it with the international one. Internationally, we are having 197 deaths per 100,000 births. So Kenya, we are even far much worse compared to the international one. But what is our goal? What is the SDG 3.1, the target? The target is for Sustainable Development Goal to have less than 70 deaths per 100,000 births. So, Mr. Ella, you can compare below 70 as a target and 355, and you see that's a very huge number. But let's break down this 6,000. What do we mean? 6,000 is a huge number.
Very huge.
You remember, Mr. Eli, the other day when there was a petrol tanker which burst into flame, killing people, and a supermarket in Nairobi also caught fire, and the government declared 5 days of mourning.
Correct.
So let us imagine it was around 200 people had died. Now, look, if it is 6,000 people dying, how many days of mourning will be that? That will be times 30. It will be 150 days of mourning, meaning we will take 5 months mourning. 6,000 days means you are having a 100-seater plane, 60 of them crashing, and nobody survives. So that's a very, very huge number. But also, globally, 712 women are dying per day, which makes it to be one woman dying every 2 minutes. So maternal mortality is a huge concern, and we need to discuss it and see the way we can tackle it. So that's the status of maternal health if we were to use maternal mortality as an indicator.
I mean, Daktari, when you talk about these numbers, they are not just numbers. These are real human beings who are losing lives. And you are able to break it into minutes. Even the biggest calamities we are having right now across the globe, so that we do not go off curve, those numbers are not equating to it. Now, go back to where you are. You practice your art in rural Kenya. When you compare the current situation in rural Kenya and in urban centers, of course, the disparities cannot be underestimated or understated. What is the greatest challenge you face as a practitioner trying to address this issue, sir?
There are several challenges, Mr. Eli. Let's start with in terms of the causes. What are the biggest drivers of maternal mortality? In terms of the clinical causes, the biggest one are what we call postpartum hemorrhage, that is bleeding after the mother has given birth. It's a big challenge because sometimes you don't have enough blood, so the mother you'll end up losing the mother. Number two is usually hypertensive problems in pregnancy. For example, preeclampsia and eclampsia. So these hypertensive problems are also killing a lot of women. But among them, we are also having obstructed labor, especially for teenage mother. You understand also in the rural areas, you are having the challenge of teen pregnancy. So their pelvic has not developed well, so they end up experiencing obstructive labor, also another challenge. But also infections. Infections are killing most of our mother. But in terms of the systemic challenges, we talk about the infrastructure.
Yeah.
Mr. Eli, in terms of the road network in the rural area, especially in this rainy season, the road network is very tough, rough terrain. So you get in case labor starts and the woman is at home, they'll take a long time and sometimes they end up delivering on the road. Number two is the availability of the infrastructure. You can get their dispensaries, their health centers, but some of these levels we don't have a theater. So in case of an challenge, you can't deliver normally. You will need to do cesarean section. So lack of theater distribution also is another challenge. But another challenge is staffing, airline. The doctor-patient ratio is very low. WHO recommends one doctor to every 1,000 patients. In Kenya, we are having one doctor to every 19,000 patients. So that ratio poses a challenge, especially in the rural areas. Most of the doctors want to live in urban areas where they can have lots of opportunities. So they usually don't like staying in the rural Kenya. So that's another challenge. But also another challenge, Mr. Eli, will be cultural issues. For some reason, even in places where we have endeavored to give a comprehensive maternal care and we have theaters, you still find that mothers are not coming to the hospitals. One of the reasons could be cultural issues. Some women believe that after birth, the placenta has to be buried in the homestead. So they prefer to remain at home. The second one, some women like to be pampered with a traditional birth attendant. So they'll prefer an area which is familiar, their home area, to deliver rather than going to the hospital. But another reason is that some women prefer that they give birth and attended to the people who they know. That is the traditional birth attendant. They feel that the hospital area, the nurses could mistreat them and will not give them special attention, which will bring us in the solution when we talk about respectful maternal care.
Yeah.
But the last point here is that in some communities, they see the hospital as the last resort because they see the hospital in a place where when you are very sick is where you go or when you are almost dying. So they usually try to avoid the hospital as much as possible. So these are some of the cultural challenges that even though the hospital is available, even though theater services are available, but still some mothers will opt to deliver at home under the traditional birth attendant, whom these days we usually refer them to as birth companions.
All right. And thank you very much, Dr. Lutta, for bringing all these things to our attention. You know, you mentioned about the issue of a mother who is supposed to head to hospital, and unfortunately, because of the road network, they are even unable to get to hospital. If they get a child along the way, because some of them will be able to maybe proceed and have successful or unsuccessful childbirth, there is also another sneaking opportunistic issue that could arise from it, either excessive bleeding or even the post-natal care that this woman will have to, or this mother rather, sorry for my use of wordings, will have to, will not be receiving because they could not get to hospital. If they get to hospital, the infrastructure at the hospital cannot allow them, or you as the practitioner, to actually attend to them effectively. It leaves me wondering, what are you supposed to do, or what are you currently doing in order to alleviate the patient from such a disparity, Daktari?
Mr. Eli, even sometimes, let me add even to the complexity. They could go to a dispensary and they can't deliver normally. Now they need to be referred to level 4s. The problem also, we don't have ambulances. So we have a weak referral system. So this also adds to the complexity. So there are some issues which we are trying now to address such complexity. One of the issues is we are trying to link up with the birth attendants, whom we used to refer to as traditional birth attendants. We are trying to link up with them and tell them, because they usually follow these clients. As the clients also come to antenatal care at the hospital, they have their own designated birth companion who they usually report to and they are checked with. So we usually tell them, in case in your locality, in your area, there's a pregnant woman, please, when labor pains kick in, accompany her to the hospital. So for us in Mumias, what we are trying now to do, when they bring these ladies, we give them a stipend, like a transport, to encourage them. Because we're in rural Kenya, somebody will be wondering, should I take this lady to the hospital or should I buy food with this little money that I have? So for us as a hospital, we have a system whereby we give them a stipend for transport to encourage them to be bringing these ladies to the hospitals. But
So
another issue
I like, just before you proceed, I like what you're doing in, you said Mumias, right? And Mumias
yes,
Level 4 hospital. Question is,
correct.
where is this stipend? Which account is this stipend coming from? I'm just curious. Is it from your personal
No,
pockets? Is it from a kitty that has been organized? Where is this money coming from?
Mr. Eli, we organized a kitty. You see, if a woman delivers in your hospital, you'll be given 10,000 by SHA. So from this amount, we organized a kitty whereby for every budget cycle, we budget a small amount of money so that we could be using it for the transport issue. So even if you are to spend 500 for transport, but you get 10,000 from that client, you see in terms of the cost-benefit ratio, it's making sense. Number one, you got the client to come, you got also the birth companion to come with her, but you also ensure that the lady had skilled birth under a healthcare. So that's the measure which we are targeting. But at the end, also the birth companion also was able to get her stipend. Mr. Eli, do you know sometimes before we used to have birth companion who would retain this patient so that they deliver them and they're given a chicken or a goat?
Wait.
So before it used to be so.
Okay. So
Yes, before it used to be so. They deliver, then they
were
are
they
given
serving as
something.
midwives, or what were they? The companions?
As traditional birth attendant.
Okay,
Before.
birth attendants. Okay. I get it. Now,
Yeah.
this is more
So now with the
complicated than I
coming,
thought.
yes, now with the coming of the new system where we said every woman should deliver under skilled birth attendant, all the women now had to come to the hospital. But some still could go to the birth companions. Now we want to tell the birth companions still, look, you won't lose. The chicken which you used to receive can give you as a form of stipend so that she also gains. So it's a win-win situation.
Interesting. I find myself in between, or rather torn in between. We have the now what you call the evolving medical science, and we have the traditional medical practice or medicine practice where midwives could actually see to it that these women who are going to be mothers were taken care of. And, well, many will argue that they did their job pretty good. Based on the evolving science that you have, how do you borrow from that and what you have now to ensure that the synergy does not completely override the dependency and the existence of that important practice? Because I sure believe it is still happening. And I see you're eager to answer. Go ahead.
Thank you, Mr. Eli. So let's start at the first level. For millennials, for many years, women being taken care of by traditional birth attendant or birth companion.
Yeah.
They used to do some fair job until complication could set in. For example, Mr. Eli, our traditional birth attendant is used to normal births. The head comes first. That's a normal birth. After birth, the placenta also comes.
Yeah.
Then, after some few minutes, bleeding stops. The woman takes bath, you give her hot tea. That's a pretty normal delivery. Mr. Eli, what happens when before birth, the woman starts having convulsions? We call it eclampsia. The traditional birth attendant is not equipped to deal with these convulsions during birth. Do you see that complexity? He was expecting the woman will deliver at 10 a.m., but at 9 a.m., the woman starts convulsing. We call it eclampsia in medicine.
Yeah.
So this traditional birth attendant is not equipped to deal with this emergency. So this woman will end up convulsing and dying.
Yeah.
Number two, during birth, the legs come out. We call it breech presentation. Traditional birth attendant is not used to this. Or sometimes during birth, one hand comes out.
Yeah.
So we had one birth companion, when the hand came out, she started pulling on the hand. And she fell 2 meters with the hand broken. And she took the hand and hid it and took the lady to the hospital. Upon doing cesarean section, the doctors found one hand was missing. Then they asked the lady, why is the hand? He said, it is here. It had broken off. So you see this scenario now when this hand has presented, the traditional birth attendant is not able to deal with it. Mr. Eli, the baby has come out normally and we are happy,
Yeah.
but the placenta remains in. We call it retained placenta. The traditional birth attendant was not able to deal with this scenario.
Yeah.
So the mother will bleed until death. In another scenario, the baby has come out, the placenta has come out, but the mother now starts bleeding. Again, Mr. Eli, the traditional birth attendant was not equipped to give fluids or to give blood in case of postpartum hemorrhage.
Yeah.
So the traditional birth attendant did some good work up to a certain level, beyond which she had no skill.
Yeah.
Which now brings me to your question now. How should we now meet these two processes? We have decided in our side, we will talk with the birth companion.
Yeah.
We will tell her, we want you to continue helping the client at home. Encourage the client to come for her antenatal care visit. There used to be 4 visits, but WHO, World Health Organization, currently recommends 8 visits. So she will help us to encourage this patient, this client, this mother to come for her antenatal care. Now, during birth, we still encourage her to accompany her to the hospital so that she can feel that she's having a person whom she knows, because for the other nurses, she doesn't know these other nurses, so she may feel lost. But if she's accompanied by this birth companion, she'll be comfortable. So that's how we are now taking the traditional and also merging it with the modern, so that we can have a very seamless transition.
Wow. Interesting. And today on Throwback Thursday, it's all about healthcare. Guess what? A lot still to be discussed, because in the next section, we'll be talking about the issue of HIV, AIDS, STIs, among others. And we are talking to Dr. Ismael Lutta as we explore the main challenges facing maternal healthcare, especially in rural Kenya. Mother baby HIV, STI transmission during birth. And for the sake of this session, Dr. Ismael is a senior medical officer currently serving at Mumias Level 4 Hospital Medical as medical superintendent. He is also a member of Public Health Committee, Kenya Medical Association. You can continue following and throw in your questions even as we try to have the conversation. Let me just look quickly through what all of you are saying, because we are streaming on different platforms. I'm gonna quickly look at the TikTok channel and see what you say. Let's see. Why would they put target under 70 instead of 0? Quite an interesting question. That is about maternal how you call it, mortality. That is the target rate, and we that is by Stella. We have disparity still remains for brown and Asian women, no matter how you look at it. I don't know. Probably we'll have to, reconsider that conversation, find out what it says. We also have, so we end up losing the mother and child because delivery is done by quack midwives. I don't know if that's the interpretation, but I'd love for you to give me your feedback on those quick, observations, Dr. Lutta. Kindly, the mic is yours.
Thank you, Mr. Eli, and I also want to thank the speaker and the listener who have asked those questions.
Yeah.
Mr. Eli, studies have shown that for the black and brown women, pregnant women, more so in the United States, usually experiences racial discrimination. So they are more likely to be ignored. They are less likely to be attended to when they call for help. Hence ending up with a poor outcome compared to their white counterparts. So that observation is true, it's factual, it's evidence-based. Number 2, Mr. Eli, we were talking about 6,000 women dying in Kenya, but previously, if you go to 2012, there were 8,000 women dying in Kenya. So these are numbers that of men and women in some war-torn countries dying. Does it mean now our labor wards have become war zones? So Even though we have improved from 8,000 women dying to 6,000 women dying, it's still not satisfactory. So the answer to the question, why less than 70 and not 0? When you are starting at 355, Mr. Eli, it's realistically, when you set these targets, they need to be realistically, isn't it so? So you cannot move from 355 and jump to 0.
Yep.
You have to set a target. By 10 years, I want to move from 355, for example, cut it off to 140. Then in the next 10 years, I want to move from 140, cut it off to 70 or below 70. So it's the nature of the challenge, the nature of the investments that need to be put. So it's not just like, believe me, we will want the number to be at 0. Mr. Eli, there's one time I did, I visited a benchmarking experience to one of the biggest private hospitals in Nairobi.
Yeah.
From 2014 to now, that hospital had experienced 3 maternal deaths from 2014. And they remember those women by their names. On that month that I was in that hospital, there was another hospital in Nairobi that had experienced 8 maternal deaths in that month. So you can see that discrepancy. And in the rural areas, it's even huge because some are dying at the community level. They don't reach the hospital. Let me also give another example. There was a lady who was delivering at home. Then the placenta couldn't come out. Placental retention. So she went to the pharmacist, and the pharmacist was trying to get it off, but it couldn't get out. So by the time she was arriving at a level 4 hospital, she had experienced a lot of bleeding, and we ended up losing the mother. So these are some of the systemic challenges with the delivery at home. Had she delivered at the hospital and the placenta retained, the doctors could have extracted it and given her blood transfusion immediately. So these are some of the challenges. So we would like the number to go to 0, but sometimes you have to realistically and set targets.
So, talking about targets, Dr. I'm fascinated with the aspect of addressing mother-to-baby STI HIV transmission, especially during birth. As a country, we have done our best. I don't know if there are any statistics you can look at and any current studies and what they say about the specific issue in our country, Dr.
First of all, when you talk about HIV, you remember in 2000 when they declared HIV as a national disaster, we were at 14%. So for every 100 people, 14 were affected. And a lot of effort then was to put place. It was declared a national disaster, free medication, free healthcare, free tests. And currently now it is at 3.7%. So we have dropped from 14 to 3.7%. That is a very big steps. Now, when it comes to mother-to-child transmission, currently we are at around 8.6%. So for every 100 women who are HIV positive, 8.6%, around 9 children will end up turning to HIV positive. But there are some mechanisms which have been put because the children, when they are given birth to, they are put on prophylactic medication. They are given medication to take until 6 weeks after breastfeeding. So when they stop breastfeeding, they continue taking those medication for 6 weeks. So most of the time, by the time they turn 2 years, they are usually HIV negative. But more efforts needs to be done. The target at the global level, they want by 2030 to have a 0 maternal to child transmission. So it means every woman who will be diagnosed that she's having HIV to be put on medication immediately, and all the children also to be put on prophylaxis, so that we can eliminate this maternal to child transmission. But still, Mr. Eli, in the rural area, we are having challenges, because if you are to deliver at home, with the health workers don't have the chance to start this prophylaxis. Number two, also, we have these extreme religious groups, which members usually visit them and they say they have healed them of HIV. So imagine you are telling a pregnant woman she's healed of HIV, she'll stop taking medication and she'll end up transmitting this virus to the baby.
Yeah.
So these are some of the challenges. Otherwise, we keep on encouraging them so that they can have negative babies. But also there's something which we need to talk about, Mr. Eli.
Yes.
Is the role of community health promoters. They used to be called community health volunteers, but these days they're actually given some stipend and they are called community health promoters.
Yeah.
They form the level 1 part of healthcare system. They go around the villages, taking care of people at the household level.
Is it actually happening? I'm curious. Is it actually happening? Because this is subject to what people have argued about the issue of SHA working or not working. But I just want to find out, these community health promoters, do you see them in your day-to-day activity?
Yes, in the village, I see them on my day-to-day activity. So usually, when people feel sick, they approach them. For example, if somebody is feeling hotness of the body, joint pains, a loss of appetite, and they think they're having malaria, they'll rush to the community health promoters. They have been given some diagnostic kits. So they'll take some blood and check whether the villager is having malaria.
Yeah.
And in case they see 2 lines, meaning it is positive, they give them medication. Because previously, a lot of people used to die from malaria because they didn't have transport to go to the hospital, or they feared the bills. But nowadays, uncomplicated malaria, that simple malaria, is just usually treated at the village household level.
And would this malaria, for example, be a threatening, what would I say, infection to a pregnant mother or an expecting mother?
Correct. Malaria is a very big threat when it comes to pregnant mothers. In fact, we have to give them prophylactic medication to prevent malaria. That's how serious it is. That we have to give mothers who don't have malaria some prophylaxis against malaria, some medication to take to assist them not suffer from malaria. That's how serious it is. So in my village, we have 2 community health promoters. They have BP machine, they have weighing machine, weighing scale, and also they have this rapid test for malaria. And they're doing some great works. They have really saved a lot of life. But when it comes to now severe or complicated malaria, they usually refer these villagers to the hospital. For example, a child comes and they are saying they are seeing things which you are not seeing. They are hearing voices which you are not hearing. Basically, that is a hallucination. So that's what happens when you have cerebral malaria. You start experiencing hallucination. So such kind of severe malaria, they'll refer this villager to the hospital. But they are doing a very great job.
Daktari, don't move away from that, the issue of cerebral malaria, because I'm still very considerate of the newborn. What are the possible complications such would cause to the preborn, or is there any? Because really, for me, the issue of maternal health care must really be addressed effectively. What are the possible complications that arise with the issue of cerebral malaria in newborns and just pre-birth period?
Some of the complications that could affect the newborn, number one is what we call infection sepsis. A child can be born, then you notice they're developing fevers. When you take their temperatures are very high. So we call this, if it's the first 3 days, we call it early onset sepsis. It's one of the complications.
Yeah.
But another complication will be birth asphyxia. The child was born, but it was a difficult delivery. So when it came out, it even didn't cry. You had to stimulate it for several minutes, resuscitate, pump some oxygen, support with oxygen. So we call this condition birth asphyxia, a condition whereby you are having difficult delivery and you are kind of asphyxiated. You don't get enough oxygen. The danger of this condition, it can cause cerebral palsy. So you have a child who cannot walk, a child who cannot hold things and is having delayed milestones. At the end of the day, you'll have a child with special needs.
Yep.
So birth asphyxia is a very common thing which usually occurs, especially for big babies. You find sometimes the baby is 4 kilograms or more than 4 kilograms. They are likely to suffer from obstructed labor and subsequent birth asphyxia.
Yeah.
So another issue which could happen is, of course, infections. Sometimes you could have infections passing from the mother to the child. For example, it could be things like hepatitis B. It could be things like HIV, which we're usually so much concerned. It could be things like syphilis.
Yeah.
That's why even when they come to the clinic for the mothers, we test for HIV, we test for syphilis, and we also test for urinalysis to check if there's any infection, because such infections will transfer to the baby when it is passing through the birth canal. So we also need to take care of this. Of course, in rare circumstances, you could have issues like congenital malaria, which moved from the mother to the baby. So you need to pick it very early and treat it.
So, Dr. in any medical field and in any medical process, I'm told there are moments we say a point that a patient or your client, for that matter, requires critical attention. And we can also call it a critical point of a patient. For the expectant mother, what are these stages of pregnancy or post-pregnancy would you mark as critical moments that require a lot of observation and the action of a health provider like yourself?
So let's start from during pregnancy. If a mother starts bleeding on the 3rd trimester before delivering, you want to follow this mother very closely. We call it antepartum hemorrhage. So you want to follow her very closely. And part of what we'll be investigating is we'll be doing an ultrasound, because sometimes we have a low-lying placenta known as a placenta previa, which can cause such women to experience vaginal bleeding before delivery. But another thing you could also notice, if somebody comes and they are swollen. For example, there's that normal swelling of the legs during pregnancy, but now you find even the face is swollen. You want to follow that lady very closely, because she could be having hypertensive problems of her pregnancy. So you want to check their blood pressure and follow them very closely. Another thing, during now convulsions, when a pregnant woman convulses, this is a woman whom you'll want to take care in a hospital, in a comprehensive setting, where you have a theater and you can do cesarean section when need be. You don't want to deliver such a woman at the dispensary or at the health center. So whenever you see such a convulsion, you need to refer this lady, if you are in a dispensary or health center, to level 4 or level 5, where they can get optimum care. So another thing which you can also address is after delivery, now you are seeing the woman is losing a lot of blood, more than 500 mils of blood, or any amount of blood that will make her develop symptoms such as dizziness, such as headache. You want to monitor this lady very closely. And if need be, also to give blood transfusion, because these are the major things that are killing our lady. But apart from that, Mr. Eli, sometimes you may not be there, but you need to advise the lady to watch out the danger signs. You tell them when you go home, if you start experiencing a hotness of the body, fevers, you have to report back to the hospital. If you start seeing there's a lot of bleeding vaginally, you should come back to the hospital so that you can always investigate and manage at an earlier time. So these are the things, some of the things which you need really to, once you notice them, you need to take care and follow our mothers very closely. Even if they were having, they may need extra visits, extra antenatal care visit, or they may need to stay at the hospital for a longer period after delivery to ensure everything is optimum.
Thank you very much. And, this is very interesting because I'm learning quite a lot in terms of the things that we take for granted when it comes to maternal health care. And probably as a country, there are things we can do better, there are things we can be able to improve. But before I go through what we will always say, the global call to action for the country at large, I want to probably get your mind on a few things from the family level. How can the family unit support expectant mothers and mothers who just had their newborn into the family? I know it sounds simple, but from the medical eye and expertise, what are these things you recommend for families who just had a newborn, courtesy of the mother who made the 9-month cycle?
Thank you, Mr. Eli. This question reminds me that as the medical community, we need to move from looking at maternal health care as a disease-based, with the signs and symptoms and complications to be managed, and move towards looking at it as a cultural issue, as a human rights issue, and as a gender-based issue. This will now change us now to look at it as a human right. Every woman deserves to give birth in a decent way and to have a healthy baby and a healthy mother at the end of that process. It's their right as from the Constitution. As a cultural issue, it means that we need to be cognizant of the health factors, of the cultural factors that are playing and influencing the maternal health. So, Mr. Ella, let's start from before.
Yeah.
Let's start with, as a family level, how do you plan about conception? Because we should start talking about it even before pregnancy. Do you think we are ready to have another baby? Maybe we're having 4 and 6 babies already. Should we just take family planning or a permanent form of family planning? Because, Mr. Eli, 25% of pregnancies in the rural areas are unintended pregnancies. The mother already is having 5 children, 6 children. She does not intend to have any other children. But because she cannot access family planning method, she gets herself pregnant. So let us start before preconception. Do you really want to have this pregnancy, or you think your family is complete? Okay. Now, since you want to have another baby, how soon should it be? Now, the idea of spacing. Because pregnancy and breastfeeding takes a lot from the mother. Sometimes the mother end up having anemia, having depletion of essential minerals. So we need to give some time for her to recover. So a spacing between 2 years to 5 years will be good. If you are to think about it, it gives the mother time to recover. It also gives time for the baby to be breastfed.
Yeah.
Because if every year you are pregnant, the child will have less time to breastfeed. Because once you deliver, it will be thrown away and the focus will be on the newborn.
Yeah.
So we also need to consider the issue of spacing when we talk about family planning. Now, Mr. Eli, now since we want to be pregnant, we are good with the spacing also, we need to consider what are the chronic diseases that this mother could be having that needs preparation.
Yeah.
For example, for the diabetic mothers, they will be encouraged to take folic acid in a bid to prepare them for the conception. So this talk need to start before pregnancy. Now, during pregnancy, we need to encourage the husband to be accompanying the mother to the antenatal care.
Yeah.
And in some setup, they usually prioritize those mothers who have come, those pregnant women who have come with their husband.
Yeah.
They prioritize them to see the doctors first, just to encourage other women also to come along with their husband.
Yeah.
But also we need to encourage the husband to be saving some amount of money, so that in case of an emergency, you already have the transport to move from the village to the hospital. And in terms of a referral system, in places where we don't have ambulances, some people rely on private means also to be having that kind of money. They also needed to have a special arrangement whereby they can be organizing their own vehicle or their own ambulance and have a small budget to fuel these ambulances to transfer the women from one institution to another. Because at the rural level, people don't have much resources. So the issue of saving money to help them at the time of delivery. But another thing also, we need to tell them that post-delivery, the lady needs a lot of support. They need the presence of the man so as to support her psychologically, to support her emotionally, because taking care of a child, a newborn, is usually very hectic. So these are some of the things which we can encourage the man to do.
Awesome. Unfortunately, I have 2 minutes. I need you to wrap up. Call to action.
So what we'll encourage, number one, at the systemic level, we encourage the government to increase the budget allocated to health. Kenya usually do 4.5% of the GDP to around 5.1%. But in Abuja declaration in Nigeria, they had committed, African government had committed to allocate 15% of the GDP to healthcare. This one will also help counties and the national government run healthcare in a good way. Number two, we encourage the government to employ more doctors, more nurses, more healthcare workers to assist. Number three, we encourage improvement on the referral system, especially the ambulatory services. We need more ambulances in the rural counties to help transport our mothers from level 2, 3s to level 4 and 5. Number 4, at the hospital level, we encourage nurses and doctors to be very passionate and to be following up on our mothers, because pregnancy is a normal thing, it's a physiological thing. It's not like a disease. So when a woman comes into the hospital, we expect her to go back while she's healthy and with a healthy baby. At the communal level, we encourage the birth companion to really assist us, not to retain this patient, but to bring patient to the healthcare system. We will still appreciate them because we want to move towards zero maternal death. But at the community level also, we want to encourage women to be attending the antenatal care so that in case there's any problems like hypertension, they are able to be picked up earlier and be treated. Thank you, Mr. Ellen.
Awesome. Thank you very, very much. That is Dr. Ismael Lutta, and he actually accepted to show up after a heavy day of work. Plus, he's observing the holy month of Ramadan. Kindly, let's clap for him in the chat section for making time to not just share his knowledge, but also the experience and possible recommendations on how we can improve maternal health care in Kenya. We have again been speaking to Dr. Ismael Lutta, who is not just experienced when it comes to matters what he does, is also member of the Public Health Committee, Kenya Medical Association, and currently serving as Mumias Level 4 Hospital Medical Superintendent. Thank you very much, Daktari, for coming, and I want to wish you the very best this evening, even as you prepare for the early morning. Tafadhali utuombe, we need that prayer.